and psych, suicide, special considerations, and something else. So we got like 6 topics to hit.
Let's power
Hopefully
through
you
it.
guys are buckled and ready to go because we're gonna get moving here.
Let's do
So,
it.
question came up about flash pulmonary edema. So pulmonary edema, does everybody have a general idea what pulmonary edema is?
Water in the
Okay,
lungs.
so fluid in the lungs. Ding, 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 ding,
She's
ding.
not here.
Oh, perfect. Let's all color at the same time. So you have fluid in the lungs. So flash pulmonary edema is associated with left ventricular infarct. Okay, so you go from a generalized left ventricular failure portion. So that's what leads to congestive heart failure. You get the buildup of fluid, it backs up in the system, works all the way around. Okay, so with flash pulmonary edema, there is an infarct that is currently happening, and basically your left ventricle just is to the point where your ejection fraction becomes basically nothing. So you have active infarct happening on that side, which will then immediately back things up rapidly, right? So you go from kind of working to virtually not working at all. And so you get that instantaneous backup because the right side's still working, it's still trying to pump things through. So we all know the left ventricle is the drive of the
body.
of the heart, right? It doesn't. It's the big pumper there. So if you take that and eliminate that, you just immediately will back up into the lungs and overflow. So does that make sense?
So,
Boom. So increasing activity, increasing the
Right.
demand.
are they most likely also gonna lose all their perfusion too? Like,
This person will probably die.
right. But are they gonna die because they just had flash pulmonary edema and they're drowning in fluid, or are they gonna die because their heart's not pumping enough to perfuse them?
So they're going to die because their heart is probably going to end up stopping
Right.
before you can even manage. Like you're going to get, as a paramedic, you're going to be standing here in the middle, and you got the heart failure here as well as the fluid
Pulmonary.
here, and you're just
And-
basically being sandwiched and being like, you can't
keep
well,
up
I mean,
with
you-
both of
yeah,
them, yeah.
You're like, okay, I'm trying to do this, but I'm trying to fix this, and this is what's happening, and so it's just going to continue to just. So that's where you have to recognize, oh yeah, we got a massive MI. We are not going to stand somebody up with a history of heart
mess.
failure and walk them to make it easier on us, right? So these are the patients you legitimately will put them in a stair chair, put them in a carrying device, something to not increase that oxygen demand on them. Now granted, if you grab onto somebody and start squeezing on them, they're going to be like, so obviously you want to try and package them as best as you can, keep them from
Yeah,
doing too much activity, okay? So does that make sense on the?
that makes sense.
Okay. All right, so just a couple little follow-up things on this respiratory stress, recent travels, recent surgeries,
Pulmonary
condition
edema,
caused,
or PE,
PE and
stroke clots.
thrombosis, okay?
Do you think?
PEs and thrombosis, and also, like with these conditions, like what do you normally do? Like if they're
Transport.
chronic in nature, like what do you normally do? You go to the hospital, you get a neb treatment. Probably times that they're like, hey, I'm out of a neb treatment, I ran out, I have a prescription, I just don't have the ability to go get it yet. Can you give me a neb treatment to buy me time to get me there? And it's like, yeah, absolutely. It's like, you don't need to go to the hospital when you know what the fix is, and you know how to fix it. It's like, we don't need to overload the ER with things that the patient knows how to fix, they just don't have the resources right here, right now to do it. Okay? All right, so any questions on respiratory? You guys are totally ready? Man, I am so excited. You guys are ready to run respiratory calls and cardiac calls. Did not mess it up at all. Love it. Yes?
I was just
See the
thinking
point?
CPAP.
CPAP?
CPAP, but it's not necessarily related to OPQ or ST.
Like, are we gonna do CPAP or are they?
Yeah,
not
just
CPAP?
looking at pulmonary edema and CPAP, yes, but I don't know. CPAP just popped in my head and
Good.
I
So
spit
that's
it
good.
out.
You're thinking, because you have created a picture in your mind, and now you've developed kind of your history, and you're like, okay, this is the pain. And then CPAP is, yeah, we have somebody with pedal edema, congestive heart failure. It's like, yeah, this patient gets CPAP. right? So that's where you create all your information, you do your investigation, and now you come up with, okay, I'm ready to act. What can I do? All right. All right, abdominal pain, OPQRST and sample history. When and how to start, how long you've been dealing with this, right? Movement, positional. Why is positional important in abdominal pain?
Might give you an idea of where it is.
Good. Abdominal pain is a large portion here, right? So, two things. Let's see. Oh, sweet, that's very good. So, in a female pregnancy, abdominal pain is an ectopic pregnancy until proven otherwise. All right? So that is just something to always put in the back of your mind, and you're going to have to ask the questions. Are you pregnant? No, I'm not pregnant. I'll say, okay, are you sexually active? Okay, yes. Okay, well, then you could potentially be pregnant. And it's like, so then you got to get into discussing last menstrual cycle, had you been pregnant before, you got to run through all those questions. But going back to the movement and the position. So with this, there will be people that you'll roll in on them. They're sitting in bed and they got their knees up to their chest. Right? And what's going to happen if you try and straighten out their knees? Are they going to like you or not?
No.
No. Oh. So, if I do that, am I thinking cardiac? Am I thinking something in the abdominal cavity? Alright, so there are a ton of different things that I'm not going to get into the specifics of all the different appendicitis, cholecystitis. I'm not going to cover all that stuff. These are just generalized questions to help you narrow down things. Palpation and rebound tenderness. Okay? You guys know what rebound tenderness is?
The pressure doesn't hurt, but the letting go does.
Right, so grab a partner real quick. Real quick. I want to see if you guys truly know how to do rebound tenderness.
Ready?
Oh, you showed me.
No pain, no pain, no pain, and pain.
Right, let's see it. Let's see it.
Ow!
Oh, Mark's got it. Actually.
Ow! Need it. You have to let off quick.
Push in. And it's a rapid.
Ow!
That does not feel great.
Uh-oh, rebound tenderness. See if you can push hard and make him fart or pee his pants. We got chucks.
Whatever cranial nerve that is, you're working on it.
Stop flexing! What are you doing?
So, this is not really the abdominal palpation where you're massaging the abdomen as you're going. So as you're doing this, you're taking the tips of your fingers and you're pushing them virtually as deep as you can go. And then the rebound tenderness portion of it is a rapid release. Okay, it's not the pushing, hey, does this hurt, does this hurt? Obviously, on your initial assessment, you're touching, hey, because you don't want to just go digging into somebody's gut, like, wham, and legitimately it hurts them, right? So you do your initial palpation, and then when you're looking for your rebound tenderness, it's a deep push with the tips of your fingers, deep in there, and then a rapid release. All right? Let's see. So we got that. Types of pain, so our AAA, abdominal aortic aneurysm. So do we know what an aortic aneurysm is?
Tearing of the.
These are gonna die.
They're not going to die because you guys are good paramedics, you guys recognize it, and it's not going to pop while you guys are there.
Depending, isn't there two different types of aortic dissection?
There-
Ascending and a descending, and one is like.
Oh, there's a multitude of them. I mean, you have,
Oh, that was just
you have
basic,
the aortic
really.
arch aneurysms, you have aneurysms, basically, you can have an aneurysm from here to here, you can have carotid aneurysms.
Because isn't there one that is like fatal?
Well,
Any of them are
No
fatal,
matter
they pop.
When they
But I mean,
pass,
like, nothing.
the aneurysm is not going to kill you.
So any of them, if they pop, the person is going to die. Unless you happen to be sitting on an OR table, probably. But yeah, so basically it's the lining of the aorta, it splits, it starts throwing up the backside, creates a balloon. If you'll see like radiator hoses on cars, they start to create that bulge. We call those aneurysms when we're doing our read checks and stuff. So bad, right? So the difference between that and an MI in pain.
oh, pain.
Is it one track?
Pain versus pressure.
Yep, so it's a tearing type sensation, pain versus the pressure pain.
Is it an acute tearing or a constant tearing?
So it's constant and it's acute.
So,
it doesn't
I guess
go away.
my question is, did the pain start with the tearing and now it's just pain? Or is it like,
It is
you
a
feel like
tearing
it's,
pain the entire time.
got it?
So it feels like basically, when it hits that point where it becomes painful, usually it's a pretty bad one at that point. You'll look at them and they are gonna be pale, cool, diaphoretic. And it's interesting, like, just people that will read details and they'll be like, hey, you're getting called for abdominal pain, patient's pale and diaphoretic. I'm like, oh, okay, and then dispatch does a really good job of slipping at the very end, history of AAA, and it's like, oh, okay, so right away, everybody's just like, oh, all right, so boom, our index of suspicion goes way up, because you're always thinking, worst case scenario, so we're like, boom, this person's gonna pop right on us, we're gonna be talking to them, and then boom, right?
So what do you do?
Huh,
Drive.
what are we gonna do?
Diesel.
There we go, we got our diesel therapy, there's not a whole lot we can do, right? Yep, so if you're out a long ways, it's flying them, you just gotta get them to the OR. That's the fix. Fluids as much as you can to maintain that pressure and still maintain that hemoglobin level. And so yeah, there's not a lot. So that's where recognition is the important thing. Of being like, oh hey, we're gonna hang out for 5 minutes, 10 minutes on scene, do this 12 lead, da 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 da. It's like, no, because now you're 5, 10 minutes, then you can be close to the hospital. So
And is
just,
it more central?
so it can be midline, it can be down, all the way down into the femoral area, it can be in your back, between your shoulder blades. It's just a multitude, but the big thing that you guys will catch is they describe it as a ripping sensation. It feels like there's something tearing wherever it is. It's like, you hear that and you're just like, yep, okay, we are going with
Get the
AAA,
chopper.
it's a proven, like, in the OR room that it's not a AAA.
So if someone has a history of AAA, if you get called to it again, is it that
Be
they
scared.
got it fixed?
Be
and-
scared.
Huh?
Be scared.
Pardon?
You're scared.
Be scared?
Just be scared. If you
Oh,
get called,
be
it's-
scared,
yeah.
right.
They were lucky to have all that time.
Right.
So, oh, it's just been accumulating?
So not all aneurysms are things that they fix right away.
Okay.
So smaller ones will be like, hey, you have this aneurysm that is developing, it's not something, we're just gonna continue to monitor it, keep an eye on it, and maybe schedule you for surgery, maybe not. And then there's other ones where it's like, oh yes, your entire aortic arch is an aneurysm. We gotta deal with this right now. So some people actually live with aneurysms, some people fix them right away.
So if someone has a history of it, then they've gotten to that point of it. If
Something
they're
has
calling
changed.
you-
If they're calling you, something has changed. So if something has changed, it's kind of like that COPD patient, they've lived with it, and now they're calling you. Oh, help us. Yeah.
So just with giving them fluids and everything, is this where we kind of drop from like 100 to 70, like you did?
Yep, because you're not able to replace the red blood cells and the hemoglobin and stuff, and so you're just basically need to loop everything out. So you try to do as much pressure regulation as you can to try and keep things as perfused, but if it's a legit pop, you're gonna be working a code before you probably even have time to start an IV.
Are you gonna work a code on a AAA?
Yeah, because it's a non-traumatic event. So if you think about it, a AAA is virtually me coming up and stabbing you in the side, so you're bleeding out, but it's all contained. We're gonna say it's non-trauma, so we're not gonna call it a trauma code thing and say we're not gonna work it. But there's blood bleeding out, so it's not a trauma-related thing. What's the heart gonna do?
Keep pumping.
Right? So it's a fluid issue. You're
Yeah.
out of fluid, right? So the heart's gonna keep going. So it's like you're gonna look down and you're gonna be like, hey, we got sinus tach on the monitor. We're good, yeah. And so you guys will learn sinus tach on the monitor with no pulse is treated the same way as asystole is treated. If you don't have a pulse, you don't have a pulse. And so I don't want to totally send you guys down a wild goose chase on that right yet until you learn a little more about cardiac stuff. So basically, it's not something where mentation, they're gonna be dead right in front of you, but their heart's still gonna be beating for a little while. And so it's something where you're like,
It's out
oh,
of
this
fluid.
just happened. They're gonna be as white as a white t-shirt, laying
An
there. And you're
Oregonian.
like, oh, I am way behind right now, way behind, so. All right, QST, location, what quadrant? You guys know how to differentiate between quadrants? Upper right, upper left, epigastric, lower, lower, right? Does it come and go?
We're just going 4 quadrants?
Yeah. Yep, 4, and then you can have like epigastric determination. Where?
What was the last thing that you said? You meant epigastric what?
Epigastric designation as well. So
Okay.
like if it's just basically this whole upper thing, we just kind of refer to that as the epigastric area. So if it's isolated to one side, then it's right upper quadrant, left upper quadrant, right lower, left lower.
Okay.
But if it's like just across, it's just epigastric. Pain comes and goes. It's called what kind of pain is that called? It gets really bad and then it lets up. Then it gets really bad and then it gets up.
Intermittent.
Peristaltic. Peristaltic. And the most common one of these, and intermittent, yes. Yes.
Good job.
And so, a lot of times, if somebody has pain like this, majority of the time, this is a kidney stone related event. What medication do we give for kidney stones, which is the best one?
Oh,
How much do we give?
a lot.
All right, you guys aren't doing doses stuff yet, but remember ranges. We're looking at ranges, right? So depending on what you look at, like 15 to 30-ish, somewhere in there. Okay. So. A lot of pain, 30. 30, yes.
30 what?
Milligrams.
30 grams.
What was the thing called?
You don't feel any
What?
pain now.
You don't really feel much of anything.
It's like a cramping type, like sensation kind of thing. So abdominal pain, hey, here we go. We can finally start talking about people what they ate here, right? So if they eat fatty foods and then they got upper pain, it's just like, okay, do you have a history? Have you had your gallbladder looked at? And so you can kind of start tracking things a little bit when it comes to the abdomen. Appendix, do you have yours? Do you have issues with them, right? Or your lower quadrant? Urine output? What happens if they have abdominal pain and they haven't had very good urine output?
Backing up somewhere.
Kidneys aren't
Or what happens if
filtering.
their urine's been really, really dark?
Something.
Drink more water.
Or UTI.
Right? So urinary tract infections, bladder infections, all can cause abdominal pains. Okay, so this is where you start to get in any sort of abdominal pain, ins and outs. You want to know your ins and outs. Deanne, how was your last one? Right? Describe it. Loose, solid, constipated. How long ago was it? It was 3 days ago. Okay, cool. How long do you normally go? Do you normally go 3 days?
Well, 4 times a day.
4 times a day. Mark's a 4 times a day guy.
Good job.
Drinking a lot of water.
Staying
Staying
loose
loose.
So you want to track those because you want to know if this is abnormal or normal for the patient. Is this on their normal cycle for it? And then if they have a fever with abdominal pain, this is a very, very important one because what's that going to tell you?
Infection.
Some sort of infection in the belly. Sick?
Yes.
Yes. Can these people be septic?
Yes.
Yes. Can they be very sick?
Yes.
All right. So make sure you check fevers on everybody that has belly pain. Okay, so just going back a little bit to that ectopic pregnancy stuff. So now it's a legitimate pregnancy. So why are we there? Right? You get an OB call. Why are we there? Huh. Why do you think we're there if it's an OB call?
Because pregnant women are very hypersensitive to
Oh,
their health.
careful.
Easy.
Careful.
Easy.
Careful.
Mark.
Oh, look at those eyes over there.
So we are usually there.
You are very acutely in touch with what's going on with your body, and if something's not right, you're like,
There you go.
I'm gonna call her.
All right.
That's-
So
I said hypersensitive
so
to
we are
their
there
body.
because something is probably not right, right? So most of the time, pre-hospital settings, if somebody's going to be having a baby, the ambulance is usually not in the thought process, right? So if we are there, something has either changed or the mom recognizes that there's something wrong, and then we get the call. If it's like a midwifery thing, if we get the call and they say there's a midwife there, that's really, really bad. Really bad, because midwives, they do this a lot. They deliver babies, it's a normal thing. So if we're involved,
Oh,
something
shit.
went wrong, right? High stress, low stress?
Hi.
For us, no, it's super low. The midwife is, whew, that's what your issue's gonna be, is getting that midwife under control. Because who do you think is gonna try and be in charge when we get there?
Midwife.
Yeah, but why are we there then?
Because she's following her protocols,
Right,
and
be-
something
because
didn't go right.
There's nothing that the midwife can do that they're like, okay, I'm out of resources. It's like, okay, well, the cool thing is like we have a little bit of resources and stuff but what's our biggest resource? Dustin?
Diesel.
Right, there we go.
What are you gonna do when we change to electrical ambulances? Can't say diesel.
Kerosene? Can we say kerosene?
That's-
or-
No, it'll be
Solar
acceleration.
panels.
Solar panel.
Acceleration.
Put your shades on. That's what it's gonna be. It's gonna be like Back to the Future. Shades on. All right, we're good. Okay, so these are high stress situations. What pregnancy is it? Are they pregnant? How far along are they? How many births have they had? How many of them were live? How many of them were premature?
Have they had
How many
miscarriages
pregnancies?
before?
Have they had miscarriages? All these, super important. You want to throw out all of those questions. How many answers do you think you're going to get in a stressful situation like that? So, the first thing that we want to know is why are we there, and what is the complication, right?